Dr. James Downar is critical care and palliative care staff physician at the Toronto General Hospital. He graduated from McGill Medical School and completed his residency in internal medicine, critical care medicine, and palliative care medicine at the University of Toronto. He has also completed a master's degree in bioethics at the Joint Center for Bioethics at the University of Toronto. His research interests focus on communication and decision-making for seriously ill patients, as well as expanding the role of palliative care in the critical care environment for non-cancer illnesses. He is the current chair of the Postgraduate Education Committee of the Canadian Society of Palliative Care Physicians.
Thank you very much for that introduction. While we're getting the computer set up, I'll simply point out that this is the key to doing this is you have to make sure that you agree in advance with all your other co-presenters what background you're going to use. John and I actually independently picked exactly the same background. And we're actually going to cover a lot of the same topics too, so you all have to take the social media. It's like, I guess it's like the academic equivalent of showing up at the Oscars wearing the same dress as someone else. So you can all take to the social media tomorrow and argue over who wore it better. Thank you very much. I have a couple of disclosures, no financial, no academic conflicts of interest to disclose at this point. I'm not spiritual. I am spiritual, I should say. I should double check that. But I don't belong to any organized religion. I don't represent any organization, although I am the co-chair of the Physician Advisory Committee of Dying with Dignity, which is an advocacy group for people with at or near the end of life, and they argue for other things that include the legalization of assisted death. I believe in changing the law. I do not believe in breaking the law, so I have never performed or assisted a death, and I do respect people who disagree with me. That said, I'm not going to disagree with people. I'm going to restrict my comments to two main points. I'm going to talk about why I think we should be allowing or legalizing medically assisted death in Canada. And I'm going to talk about some of the common arguments against medically assisted death, which Dr. Berkman has touched on, I think, virtually all of them. And I'm going to talk about whether I think they're valid. So why should we allow medically assisted death? I often rely on I think, to be flippant, let's look at Woody Allen's famous quote, that I'm not afraid to die, I just don't want to be there when it happens. I think all of us do have an image of what it is like to die, and maybe some of us have actually seen relatives die. And there are aspects of it that we don't really like, perhaps memories or images that come to mind. And I think many of us would like to avoid that if it is at all reasonably possible. Maybe to take it more to the academic sphere, my co-presenter, who you're going to hear from, Dr. Sumner, put it very well, and I think he summed up my own feelings on this when he said, I don't know how I want to go, but I do know that I want to be the one who decides. I think most of the Canadian population agrees with me on this, that regardless of how you define assisted death or assisted dying, somewhere between a majority and a large majority support the legalization of medically assisted dying in Canada. This support crosses all regions. It crosses both genders, all age groups, languages, incomes, and party affiliations. It even touches on many religions. I am going to make the argument that death is in fact a controlled act in Canada right now, that the timing and manner of death are arbitrary. Suicide, for example, is legal. You are allowed to make a choice to discontinue feeding, artificial or natural feeding of yourself. You're allowed to discontinue hydration, knowing that that will result in your death. That is not illegal. And somebody who has the misfortune to be in a critical care unit, critically ill and dependent on life support, is perfectly allowed to request to have that life support discontinued, knowing that it will result in their death. And I call the family in to be at the bedside because I am relatively sure I'm going to know when that death will take place. I think that legalizing medically assisted death for that reason does not require a major shift in our ethical mindset, because I believe that death is already, to a large degree, a controlled act. Some will argue that causation is the difference, that when you withdraw life support, you are not causing death, but merely allowing death. I think that's an argument that can be made, but I think it's not a strong argument, because fundamentally the difference between causing something to happen and allowing something to happen is very, very gray at times, and I think that other members of the panel will be better equipped to explain how that can happen. But certainly, I think you need to recognize that somebody who has a terminal illness and requests to die, that request comes from their terminal illness. It is very clear that the request to receive an assisted death is related to the illness from which they suffer. And if somebody is not in a position to be able to legally commit suicide stop their feeding or hydration or turn off life support, they're left with the alternative, which is to wait for a fatal complication. And I think I agree with my colleague Dr. Berkman, who says that we should not use euphemism, we should not clean up our language, but we shouldn't also clean up death, and we should remember that death can be a very unpleasant experience. I have seen people drown on their own blood while their family watched. I've seen people with tumors eroding into their airways who choked on mucus and suffocated in front of my eyes before I could get any medication into this person to relieve that suffering. I was left wondering why that was necessary. Clearly, I don't have to do everything that someone asks me to do. I have the right of conscientious objection. It is well enshrined in our professional codes. But my right to conscientiously object to performing an act does not extend to a right to prevent somebody else from receiving something. The bar to cause a societal ban, or the bar to justify a societal ban for something is much, much higher. You need to demonstrate that there is a demonstrable need to protect a patient or to protect society by outlawing something. In other words, you have to come up with a very good argument against medically assisted dying. And I think I'm going to review some of these arguments, many of which you've already heard, and I'm going to show you why I don't think any of them bear out. The argument that you've heard here, that palliative care is always able to control symptoms. Physician-assisted death will grow and become a replacement for palliative care. There will be no ability to protect the vulnerable. These are the so-called slippery slope arguments. Other arguments like physician-assisted dying will harm the doctor-patient relationship, and if I have time, I'll even go at the Hippocratic Oath. When we say that palliative care controls all symptoms and relieves suffering, you need to know where that comes from. The empirical basis is that in studies of palliative care and symptom control, we decide that someone has symptom control when they have a 20% reduction in a symptom score. Here are 9 patients from a trial of early palliative care for lung cancer. These are quality of life scores, not pain scores, but it illustrates the same point. And you can see that each and every one of these patients has some degree of movement of their quality of life score over time. Some of them go up, some of them go down, some of them go up and down. But essentially 8 out of 9, or certainly, depending on how you define it, somewhere between 6 and 8 out of 9 of these patients at some point have a 20% increase in their score. But I would say that probably only one of these patients clearly got better. Almost all of them were simply bouncing around. All of them would fulfill the criterion of having had their symptoms controlled, but I don't necessarily agree that we've done anything. And I think the proof is also in the pudding when you look at the patients who request assisted death where it's legal. In 2012 in Oregon, of those who requested assisted death, 97% were enrolled in a palliative care program. Clearly, palliative care was not enough to provide for their needs. We also talked about, Dr. Berkman also talked about the difference between physical and non-physical pain. I'm sorry this doesn't project well. But it's important to remember this is the cause of requesting assisted death for patients with ALS. All of the things at the top are wanting to control circumstances of death, fear of poor quality of life, loss of independence. These are things that palliative care cannot fix with medications. Pain at the time of request comes in at number 19 on the list. It is rated 2 out of 5 in terms of importance. And we also have to remember that palliative care is only available to a small minority of Canadian population. I think it's a bit disingenuous of us as an end-of-life caring group to continually advocate at the governmental levels for increasing resources, telling people that we can't provide for care, for end-of-life care for all Canadians with our existing resources, and then turn around to the Right to Die movement and say, don't worry, we've got this. The slippery slope arguments. Many people argue that physician-assisted death will slowly grow and swamp and replace palliative care. The evidence shows that probably exactly the opposite is true. After 15 years of legalization of assisted death in Oregon, it now accounts for a whopping 0.2% of all deaths that occur on an annual basis. In Holland and Belgium, the numbers are higher. They float between 2 and 3%, but these are actually lower than they were prior to legalization. So in fact, legalization has led to a reduction in the rate of assisted death. What has been stark has been the growth of palliative care, well-documented growth of palliative care and hospice services, far, far outstripping the growth of assisted death or the use of assisted death in Oregon. Oregon now has the highest rates of hospice referral, opioid prescription, and end-of-life communication in the United States. Huge increases in hospice referrals since legalization. Physicians are self-educating themselves and moving forward in their knowledge about palliative care practices to a degree that was never seen in the pre-legalization days. The vulnerable. We hear about the vulnerable and how this is disproportionately affecting the vulnerable. Let's look at the facts. These are the 1,200 people, or almost 1,200 people, who have received an assisted death in Washington and Oregon since legalization. Here are the demographics. Fewer than 15% were over the age of 85, 95 to 97% white, 93% high school graduate or better. 1 to 2% had no health insurance, so 98% had some form of private health insurance or Medicare. Keep in mind that 40%, up to 40% of the American population prior to Obamacare had no health care. The major concerns were not anything to do with financial implications of treatment or the burden on the family, far more so loss of autonomy and inability to engage in enjoyable activities. Hot off the press, study from Switzerland, demographic of Swiss patients receiving assisted death, looking particularly at the senior population above age 75. So these are odds ratios for the likelihood of receiving an assisted death based on, so if compared to compulsory education, which had an odds ratio of 1, those who had secondary education were 74% more likely to have received an assisted death, and those with post-secondary education were almost 3 times as likely. Depending on where you lived, if you lived, compared to those who lived in a household with more than 2 people, those who were institutionalized were 16% less likely to receive an assisted death. And each and every quartile of income was associated with a measurable and significant increase in the likelihood of having received an assisted death. In other words, the best way to protect yourself from receiving an assisted death is to make yourself as uneducated, institutionalized, and poor as possible. In other words, try to make yourself vulnerable as fast as you can. Assisted death in the Netherlands over time has clearly gone down. So from the pre-legalization days to the post-legalization days has fallen overall. And we've heard a little bit today about the so-called life-terminating acts without explicit request, or Downar cases. So these are the cases where patients have received an assisted death without fulfilling the criteria set out in the legislation. To many people, this is proof positive of the failure of safeguards and the existence of the slippery slope. Notice that the slippery slope is actually slipping upwards, that now post-legalization, life-terminating acts without explicit request are about half as prevalent as they were prior to legalization. And let's look at the cases themselves. Many people consider this equivalent morally to involuntary euthanasia. But let's look at the medications that these patients actually receive. So this is a manuscript in preparation that will be published hopefully in the near future. If you compare the medications received by patients getting palliative care, so just simple symptom management that is legal here in Canada, on one extreme, and then on the other extreme, those who receive a legal assisted death, and then you look at the lower cases. The lower cases look exactly like those receiving palliative care, and very much unlike those receiving an assisted death. And when you look overall at the details of the case, the presence of a request to die, whether or not it met the legal requirements set out in the state, and whether or not there actually was medication given that could conceivably be responsible for the death of a human being. In fact, 45 out of 66 received what would only be considered symptomatic therapy, in other words, palliative care, or they had made a clear request for assisted death, albeit one that did not meet the requirements laid out in the legislation. So I think it's very clear that Downar is not equivalent to involuntary euthanasia. And then you have to ask the other important bookend to this question, is that if you're going to say that legalization and safeguards that come from legalization have failed, I think you need to look at the success rate of the safeguards in place in our society and in other societies where it is a blanket ban, and ask yourself, is that an effective way to prevent involuntary euthanasia from taking place? The answer is no. 3 countries here, Denmark, Italy, and Sweden, doctor-assisted dying. All 3 countries, this is completely illegal. And in fact, not only does this appear to be taking place, but in some cases, the numbers are actually higher than in countries where it is legal, where I should say assisted suicide is legal. 1/3 of Australian surgeons say they have given medications with the intention of causing death, often without a request. 5% of deaths in New Zealand in one survey, done very similar to the European surveys, meet the criteria for assisted suicide or euthanasia. The short answer here is that the best way to protect the vulnerable is not with blanket bans, but with visibility, with bringing things out in the open and doing things in a regulated and legal manner. There's concern about effect on the physician-patient relationship. Surveys from Oregon clearly show that patients who opposed assisted suicide after legalization were twice as likely to report that a patient had left their practice as a result of their opinions compared with physicians who actually supported assisted suicide. And with time, although about 80% of physicians didn't change their opinion on the law, 13% of physicians became more supportive of assisted death compared with only 7% who were less supportive. I have 3 minutes to talk about the Hippocratic Oath, because this is a common thing invoked, that killing a patient fundamentally runs contrary to our ethic as physicians and the oath that we take when we graduate. Let's go back to the original document. The original Hippocratic Oath, I wasn't around at the time, but the original Hippocratic Oath swears by the original Greek gods. Well, we got rid of that. It does ban giving a deadly drug, but it also bans giving women an abortive remedy. Well, we've taken that out. There's also that awkward part about only men being taught medicine. Took that out too. The truth be told, that the Hippocratic Oath is now not even used as part of the graduation ceremony in up to half of medical schools in some parts of the world, for the simple reason that it is not the gold standard of ethical practice and legal practice. It is probably more properly coded as a rite of passage, one that is modified in order to meet the social mores at the time. I think this may offend Hippocrates, what we're talking about today, but I think the more valuable lessons that I learned in medical school were to read the literature and to listen to my patients. And it turns out that the literature and my patients both have a very different view of assisted death than Hippocrates did. So I think you have to remember that when you look at the major arguments against assisted dying and you look at the actual evidence that's out there, none of these, not one of them, bears out. And I'm going to leave you finally with my good friend and mentor who passed away just this fall, Don Lowe. And I think I take his message to heart. There are a lot of clinicians who are opposed to dying with dignity. I wish they could live in my body for 24 hours, and I think they would change that opinion. Thank you for your attention.